Good morning, everybody. Really lovely to see such a fantastic turnout for the second in the series of the Core20PLUS5 Learning events. There's lots of familiar faces to me on this screen. So for those who don't know me, my name's Kim Shuttler. I'm here today to chair in my capacity as the VCSE sector lead for West Yorkshire ICB, but some of you will know that I also run a mental health charity based in Bradford. Just a little bit of housekeeping, although I see people are cracking on with it already. If you could just pop your name and organisation into the chat, that would be great, so that we can see who's here today. It looks like we've got a nice mixture of people from Bradford and outside of Bradford. If you can keep yourself on mute, that would be great. And we are going to be recording the session, so if you don't want to be on camera, please pop your camera off. So today we're going to be hearing for some brilliant speakers who are going to be sharing their experience, and there is going to be an opportunity in the session for you to ask lots of questions. So have a little think, and then we're going to do that at the end. So if people want to say that's it, or if you want to pop those into the chat, that's okay. I'll do my very best to try and keep an eye on the chat for at the end, but I'm sure there's lots of things that people would like to ask. So, second in the learning event, I know that we had a brilliant turnout at the first one, and it just shows, doesn't it, how incredibly important this topic is to so many people. I'm really proud to work in Bradford District in Craven, and one of the reasons I feel proud is because of our focus on this area. We know, don't we, everybody on this call will know about the shocking health inequalities that our communities are experiencing, and we see it every day, don't we? We see it every day, and I would take a bet that most of you on this call are incredibly passionate about doing something to turn the tide on this stuff. So to address this at a national level, the Core20PLUS5 programme was introduced nationally by NHS England. I don't think we were needed to be told actually in Bradford that this was a really important area, but actually this is a brilliant programme that's given an additional area of focus. And for those who aren't aware, it defines the target population cohort. So it identifies a core 20 of the most deprived areas, and then 5 focus clinical areas, which really are about picking out the areas that really need a big focus, a big acceleration. So in typical Bradford District and Craven style, I think an amazing approach to how this was deployed, and really working in partnership with across our partners, including the VCSE, which was obviously I'm very happy about, to knowing that is the best way to do this work, to really work together to reach communities. And Bradford District and Craven worked closely with 13 community partnerships, and very much recognised that locally was best, getting local, as close to communities as people as possible. Those are the people who know what matters to them, but also bring that together with the really strong evidence base. So today, what we're going to be doing is focusing on the Core 20 bit. I think there's other bit. I think there might be another session looking at the +5 bit, but we'll be talking about some of the work that has been on reaching those living in the 20% most deprived households. What I meant to say actually is this is even more important in the light of the government strategy. People will have seen, hopefully, the 10-year health plan, and this is absolutely central to that work. So what we hope is that this session today and others will give you a little moment of inspiration. Think about what role you might play, and also how do we take this learning? How do we take the really important warts and all learning from our colleagues and take it into the future, so that we can really drive this forward? Because I think we'll all be in agreement that our communities can't wait for the improvements that we need. So today, I think I've covered everything on my brief, but today we are joined by a brilliant panel who are going to tell us a bit about some of the stuff that they've been working on. So firstly, I'd like to introduce Abida, who is from the Core20PLUS5 team, and she will talk a little bit about the Core 20 bit. But we've also got here today Mandy, don't know if people can give us a little wave. You can use one of those like emojis to give us a little wave to say who you are. Mandy Lakes, who's come from Project One, Community Health Checks. And then we have also got Pam Essler, and I think Pam might also be joined by Aisha and Bill Graham to talk about the KCAN Keighley Cancer Champions project. I think, hey, Pam, or are you flying solo?
Aisha couldn't make it this morning, so Bill Graham is joining me, hopefully, says she, fingers crossed. And we've got Naz here too from our core partner sort of in this work, so she'll help answer any questions. So hopefully we got it covered.
I think definitely got it covered. We've got some incredibly experienced people here today to talk. So without further ado, I'm going to hand over to our first speaker, who is just going to talk a little bit about, from the perspective of the core team, about the Core 20. Thanks, Avida.
Thank you very much, Kim. I hope everyone could hear me okay. So thank you for joining us this morning. So my segment for this morning is about talking about the Core 20. So as you can see from my first slide, which I just need to make sure I've got my notes. Yeah, so as you can see from my first slide, we're looking at the map of Bradford and Craven, which, as you can see, there are quite big challenges when it comes to health across the access to care. So the darker colours are the more deprived areas. And like Kim alluded to, Bradford is quite a deprived place. It's ranked the 13th most deprived across the 317 districts in England, which means half of the people here are part of what's called the Core 20. So those that are most affected by poverty and health issues. And I guess facing multiple deprivation also includes wider social determinants of health, such as income, poverty, employment, work conditions, housing, your environment that you live in, discrimination and racism. And it's also really important to look at this through quite an intersectionality lens as well. And in doing so, we know that that will help us deepen understanding of who is actually and really affected and why. It'll also help us strengthen equity in the services that we deliver. And I guess it also will put a spotlight on the blind spots in policies and programs that we do co-design with our communities and local residents. And obviously, ultimately, it's about truly being inclusive when it comes to public health strategies. So this slide basically illustrates the Core 20 and how it's being applied locally. And then obviously the deprivation and where there is that higher concentration of need. And as you can see from this slide, it's in the south and east parts of Bradford. So with 34% of the lower layer support outcome, which basically puts us in the bottom 10% nationally. And that means that 50% of the population falling into the Core 20 target intervention, which is quite critical that we've got Core 20 in Bradford. So if we move on to the next slide, please. So the next slide, basically, what this explains is our Core 20 approach in Bradford, which obviously we know is a national strategy. It targets the most deprived area, which is a 20%. And obviously that is based on the index of multiple deprivation. So for the index of multiple deprivation, we've got 7 indicators for that. Again, I've alluded to that in my other slide. But it also includes things like education, skills and training, health and disability, crime, barriers to housing and services, and again, your environment. So with Bradford District, we know that half of this population falls into this category. You will see from the table in the middle, which outlines our 13 community partnerships.
Oh, yeah.
Sorry, was there somebody coming in? Okay.
I think someone's just not on mute. Go ahead.
All right, okay. So as Kim alluded to, we've got 13 community partnerships. So for example, we have the BD4+, which is situated in Bradford South. We've got WOW, which is also Bradford South, and Together for Health, which is in West. All our CPs align with the localities as best as they could. And these partnerships are essential in delivering the tailored health service to the most deprived population. That's why the local groups in this table are working to focus on exactly who really needs that service and taking a very hyperlocal approach. And the main aim is pretty simple. It's making sure that people in our most challenged communities get the best access to health services and support. So the focus of the community partnership is on improving access and services, specifically for those groups. And I guess it is to ensure health equity is actively addressed where it's needed the most. So if you can move on to the next slide. So this slide basically is a snapshot of the Core20 programme when it comes to looking at Bradford and District Craven. On the left, we see the percentage of participants in each community partnership, and obviously where there are the most deprived areas, so specifically IMD 1 and 2. So some of our community partnerships, such as Together for Health, CP5, Keighley and Worth Valley, have done particularly well. It has reached 85% of their participants from those high areas of need. But then in contrast, we've got community partnerships like Craven and Bingley, who have much lower representation, which is under 10%, which generally reflects the general lower level of deprivation in those areas. And on the right, you see the bar that shows ethnic diversity of participants across the partnership. So again, in these areas, you've got your community partnerships that have engaged overwhelmingly with Black, Asian and minority ethnic communities. And again, the bar chart demonstrates that there's been rates of 90% engagement. But that also then highlights where we've had lower level of engagement from the minority communities. And the main reason for that is because some of our CPs are situated entirely in areas of deprivation, whereas in other CPs, the communities, there's a lot fewer from the minority communities. Therefore, that's the challenge, to reach and engage with those particular communities for our Core20 projects. But altogether, both of these charts highlight where the programme is reaching its target population, as well as where there's room for improvement in terms of equity and inclusion. So Sophie, if you can move on to my final slide. So my final slide shows us the chart which brings together the demographic data as well as the white IMD data for all the communities. So you've got your white British, Black, Asian and minority communities. And again, community partnerships like Together for Health, HCHC and CP5 have a higher minority group participation, whereas again in Bingley and Wilston and Silston and Craven, which are predominantly white British, they have lower levels. And then you can see how there's high deprivation in our IMD 1 and 2 in the more diverse areas. So basically the upshot is that it's visible that there's a link between ethnic diversity and high deprivation in some of our areas, and it's useful for us to target these health interventions to make it more equitable. So this illustration also just reflects where engagement is with the most deprived communities of the Core20 is strongest and where improvement is needed. I hope that you've all found that really informative, and thank you for your attention. Came back to you for our next Core20 project.
I was just struggling to get off mute. Thank you so much, Abid. There's such rich information in there, and colleagues will have also seen, hopefully, in the chat that Joe House has posted that if people want some more information about the Joint Strategic Needs Assessment, there's a link there. And will we be sharing the slides afterwards, Abid? Because I think that was brilliant, and I'm sure that people might want to take a bit of time to look at that in a bit more detail. Okay.
Happy to share slides, yeah.
Brilliant. Okay, so we've had a little bit of an overview of what the picture looks like in Bradford, and so we're going to hand over now next to Mandy, who's going to be talking about community health checks. Mandy, oh yes, I spotted you, looking lovely in pink.
Thanks, Kim. Thanks, guys. Lovely to be here. Thank you for having me. I'm actually here representing my colleague, Mohammed Mahboob, who couldn't make it today. He's one of the community health development workers that's been involved in a lot of the health checks in the delivery. But just as a disclosure, if you don't know, I was part of the RIA team in healthy communities as a Reducing Inequalities manager. So I was involved in the WOW Bradford South health checks as well. So a little bit of kind of background there. So I'm just going to share if I can. Everyone see that okay? Wonderful, thank you. So just reaching the 20%, and this is just a little bit of a run through around the community health checks model. So what was the inequality? The issue, as we sort of discovered, as Abid has given us some background there, by wards, looking at the data, our community partnerships did see that there were some real concerns within specific wards around high rates of health issues, such as diabetes, pre-diabetes, low number of hypertension case finding, and also alongside that, lots of barriers in accessing services, which we know is often heightened in our lesser reached and seldom heard groups as well across the district. The most deprived in our community do have a lower life expectancy. I know Sahil touched on this yesterday, if anyone was present, that we have a shorter, healthy life as well within our poorer communities than our wealthier communities across the district. And I think that's up to about 20 years. So that's quite astronomical, really. So that was the inequality. Ooh, is it going to let me move it forward? Yep. So what was the solution? So the solution was, of those, as Abida mentioned, 13 community partnership areas, 6 of the most deprived got the biggest kind of chunk of money to work on health inequalities. And 4 out of those top 6 most deprived community partnerships did identify a need for health checks within their local communities. And this involved a really joined up approach from the whole community partnership members, which included GP practices, PCNs, pharmacies, living well, ward officers, voluntary sector, community and faith settings, social prescribers and health services. So the community health checks were carried out in mosques, voluntary community sector venues and within clinics. So they were out in the communities where people were already accessing services. And this was really valuable because as well as getting the GP text messages about the event, we also tied into when we knew there was good footfall within our venues, so that increased the numbers of people actually accessing and then reaching those that don't normally access a GP as well, so capturing those. As part of the health check rollout, we also shared good practice through a community of practice, which Joe House led in the REA team. And that included a creation and rollout of a gold standard health check model, which I'll touch on in a minute or two. And then most of the health checks are still actually ongoing till the end of March 2026 when the funding comes to an end. Some of them have one a month, bi-monthly, quarterly, but they are still happening across the community. I have to move you over because you're blocking my words. There we go. There's 2 of my lovely staff there, Mark and Mohammed. So the impact on learning from the health checks is that actually 3,000 people were reached across all the health checks, which is amazing. Multiple services at the health checks created a one-stop shop. 73% of participants were in IMD 1 and 2, so that 20% of most deprived across the district. Living Well community worker Mohammed, who I'm representing today, felt that he was able to have friendly and open conversations with individuals in a setting that was comfortable to them. So it was reaching them again where they go, where they feel comfortable and where they're open to have those discussions around their health. Health checks did reach a wide range of people who don't attend the GP generally. It provided a clinical service, but also a range of health messages and offers from a variety of partners. So smoking services, cancer awareness, healthy eating, they were all present at the events. And it was also supporting statutory and voluntary partners to enhance their working relationships. So through that joined up approach and that joined up working, they've built some really strong relationships where they can continue that work and that collaboration. And attendance increased across the areas in regards to the stall holders. So when the events first started, there may have only been 1 or 2 additional stalls that were kind of attending the health checks alongside the GPs and the social prescribers. But as the events have continued and have grown, and those connections and connectiveness have grown with it, then lots of the events now have multiple partners that are attending. That's all brilliant in reaching more people with a wider range of messaging. And then this is just the takeaway, the long term. So as well as multiple benefits to individuals through case finding, which is obviously massive, because if you identify health issues earlier and have those conversations with people earlier, you are then preventing long-term and severe health implications in the future for those individuals. But there's also, on top of that, been a real benefit in supporting the 20% in future work, because we've learned, we've collaborated, we know what works, and actually taking that forward has been really useful. So, for example, lots of our community venues and voluntary sector organisations are actually still reaching out to Mohammed and saying, this event was really good. Can you come and collaborate with us? Let's get people to a wellbeing event. So lots of that work is now continuing sort of over and above and around the health check model. So we've built and established those relationships. And partnership is vital to make the model work.
My name is Sonic. I'm a visual artist, and
we've spoke to lots of our partners, such as Locala, Cancer Smart, Prostate Cancer, that are often there regularly now at events and health checks. And they've said that their knowledge and networking has been vastly improved because of the work through the health checks as well. And then final page, if I can move it forward, is, I'm not sure if it'll let me open this, but I'll give it a try. This is the health check model. So if we will share these slides. So if anyone does want to have a look at the health check model in finer detail, then it's there, it's available to take learning from that. And then I think we're going to try and show this message from Kieran, this just little video. And so Sophie's on backup in case it doesn't play through my machine. I'll see how it goes. Yay.
Mandy, I don't think there's sounds on it. Just when you share it, there's an option to share it with include sound. I think you just need to click that if that's okay.
Is that on the actual Teams?
Yeah, so if you stop sharing and then share again, and when you click share, it should say include sound, and if you just click that button. If not, I'm happy to do it.
Yes. No, I've got it. You're right. Got it.
My name's Kieran. I'm an A&E doctor by background. I'm a project lead at the Improvement Academy working on the Community Health Checks project. Cardiovascular disease is strongly linked to socioeconomic deprivation, and in Bradford we've got some of the most deprived wards in England. So you can imagine we've got a huge problem with cardiovascular disease. But cardiovascular disease is highly preventable through early detection of things like blood pressure and cholesterol. And if we detect and treat those conditions early, we can stop people progressing to having major illnesses such as strokes, which are obviously devastating for members of the community. But high blood pressure and cholesterol often have no symptoms, so people are unaware they have them until it's too late. So when we took this issue to communities, we found there was a real enthusiasm to collaborate with us and do something about this problem. So we worked with the Bradford Council, with VCS organisations, and with the health service and primary care providers to deliver a series of health checks in community setting, looking at people's heart health. So that's looking at things like blood pressure and cholesterol testing and diabetes testing, as well as connect people to social prescribing and other organisations in the area that can help them to improve their health.
Hello, my name is Ali. I'm one of the imams and the teachers here at Masjid Military Islamia in Bradford. The community service was a great incentive. We had over 70 patients come in and use the service. The over 70 people that we had, more than 10 of them didn't even know that they had diabetes. So given that this is a trusted place, they came in, they used the service available to themselves. It educated them, because coming from a South Asian background, especially in this area, it's a trusted place and they're slightly uneducated on the matter. So coming in and having those talks with them so they are aware and raising awareness about diabetes was a big help.
From speaking to people at the mosque, we found that people are struggling to access healthcare services in the traditional way that they perhaps used to. So it's really important that we can provide this kind of service in a different space that's more accessible to people, such as the masjid here. The important thing is that people in the community are having a conversation about their blood pressure, and an event like this can start that conversation. But the community members can really support people to make a difference to their blood pressure long term. For example, the MOS community members here have bought themselves a blood pressure machine that members can use every time they come for prayers or for community events, and keep an eye on their blood pressure long term. And that's a really sustainable way that people can improve their blood pressure and heart health.
The community health checks have worked so well in the masjid, especially because the community around that area is definitely a majority Muslim, and this is an area that they trust. Whereas other surgeries and partnerships, they don't necessarily have that connection with the people there. They see the doctors as professionals doing their job, whereas they see us as people, common people who are like them. It's a place where they feel that they're connecting with the people. It's something that they can relate to, because we're common people like them. We're not professionals.
So over the 5 events we've done so far, we've seen 290 people in total. Many of those have had a new diagnosis of high blood pressure or diabetes following the event, and those people are now in a position where they can seek treatment for that and make changes to their lifestyle to improve their health and stop them having heart attacks and strokes in the future.
This project was an excellent example of what can be achieved when faith groups such as ourselves work with the NHS in order to deliver projects, because we can break down barriers and reach to groups that wouldn't be reached.
I think there's huge potential from going out and working in communities, and we can learn a lot as a health service from doing that. And I think when we do go out, we find that people care about health inequalities and they want to improve their community's health outcomes. And as a health service, I think we need to listen and respond to that in whatever way we can and support communities to improve their health and well-being.
And that's me. Thank you.
Thank you, Mandy. That was a really powerful video at the end, but brilliant, practical story, which leads to some amazing outcomes for communities. Please do have a think about what questions you might want to ask Mandy at the end. You can either pop them into the chat, or I'll come back. I'll come back after I've spotted one hand, but I'll come back to you later if that's okay. So we're going to move on to our second project, which is KCAM, Keith League Cancer Champions. Now then, we have got Pam, we've got Naz, and has Bill joined us? I'm just trying to flick through my screen.
I've been here since the start, Kim.
Have you, Bill?
Yes.
Well, I've recognised that voice everywhere. I can't see you, but I know that it is definitely you from that voice. So, okay, brilliant. But we've got the dream team here to talk about KCAN, so I will hand over to you guys to share some of your learning and what you've been doing.
Thank you very much, Kim. And like you, I was panicking Bill wasn't here, as you might imagine, and so on. So where did the KCAN work start? It started with the Keighley and Worth Valley Community Partnership, taking a step back to look at the data and see what their priorities should be and how they should begin to address them. And the data showed us that outcomes for cancer were much lower than you would want, that this was largely due to late presentation, and again underpinned by the fact that there was a low level of uptake of screening programs. And this was despite the work that our local primary care network had started to do to try and sort of address some of that. So it's obviously a broader, more intensive approach was needed. And this is where the KCAN work started. So Bill is going to take you through an overview of it, and then I'm going to do a little bit actually sort of focusing on a key element there, which was the community health champions. So over to Bill.
Hi there. Yeah, good to see everyone. Just if we had the slides back, please.
Sorry, Bill, I didn't know if you wanted to share them yourselves, but I'll get them back up for you. There you go.
Well, I can share this. Yeah. Just the context actually is in 2021. Me and Naz actually had a chat about cancer screening, because it was a bit of an issue that, you know, figures weren't great for some of it, and we chatted a bit about it. And in 2021, we actually got some funding from the Reducing Inequalities Alliance, which ourselves as the one PCN. We kind of started doing some work, you know, getting some champions trained up to have conversations with people in the community about cancer screening and to try and demystify it. a bit and try and understand some of the barriers. So that's kind of where this work started. And the learning from that, because Cancer Alliance wanted their learning, the learning was to involve the other PCN in our area, which is WACA, and also to involve more communities, more groups. So that's maybe where the idea of wider Keighley champions came from. So we'd kind of done quite a lot of work on the ground on this the year before the community partnership got involved. But then we were able to give the community partnership a good offer because we'd already kind of trialled a bit of this. And we also went back to Cancer Alliance to get money, which Naz got some cash for the champions, and I managed to get some cash for Modality WACA to work together and to create some workforce. If we just move the slide along, there's not many slides here. So the partners was as a partnership between the PCNs. So we work in partnership with WACA, 2 PCNs working together across geography. The partnership with the community partnership, which is Pam and the community partnership there. The partnership with community and VCS, which CAWAC and the rest of the community champions, they're all on that KCAN slide there. And partnership with West Yorkshire Cancer Care and West Yorkshire Cancer Alliance. So we kind of have a really good, solid foundation for this work. Just on to the next slide. We appointed within our teams a WACA cancer champion and a Modality cancer champion there, who are accessible to the champions, can answer queries, can turn up at events. Jenny's a trained nurse. She runs additional cancer screening sessions, cervical screening sessions as well. So that continues to this day. On you go, next slide, please. Yeah, it's a good partnership, works really well. Pam and Naz might touch on a bit more about the champions' involvement. I know Naz has got some slides. They made my computer crash this morning. The very big file, but yeah, the cancer champions are in the communities, going to lots of events, having lots of conversations, really raising awareness about how you'll be invited for your screening, what your screening entails, being able to answer the questions that people might have been a little bit worried about what cancer screening is. The way you're invited to screenings is very different. I'm at an age now where I even get a bowel cancer test in the post every 2 years, and I need to send that back. So being able to explain to people how the different cancer screening invitations work, what it entails, and demystifying it a bit, really important. And we've even worked with some of the screening providers, such as Pennine Breast Screening, to do trial sessions for patients to go and meet the team and see what breast screening is involved. What's involved with breast screening? Because again, there's a lot of demystifying what all this means, and that's worked really well. We've run some pop-up sessions as well. That's for cervical screening, because that's what primary care does. That's the one bit that we can have a very sort of targeted impact on. If we go on to the next slide, please. We've run a lot of events in partnership. Last year we had a Women's Health Month with in the surgeries, in waiting rooms, all the surgeries in Keighley took part. If you move on to the next slide, just quickly, we are the next slide. If anyone's doing the buttons there, yep. And this month, or start of October's tomorrow, isn't it? We've got again October. We're doing it's Breast Cancer Awareness Month is October. So that pink poster there is the events that are happening in Airedale again. Well, they're actually expanded out a bit. There's an event in Milkley, there's an event in Skipton as well. So again, that's everybody working together, raising that awareness, which is really important. Now, the key thing is, and I think Mandy's slides sort of touched on this as well, is the so what. If we go on to the next slide, and because we've now been doing this for 4 years, we can really have a dig into what the cervical screening figures are locally. So we can see cervical screening as, just year on year, that 25 to 49-year-old age group. Now, that's a really big cohort. That's a lot of numbers. That's gone up 2.5%. So the percentage might not seem much, but in numbers, it's quite a big turn. And then the 50 to 64-year-olds, it's gone up 8.7%. Now, I think it's a combination of the PCNs having those cancer champions, having a focus and practice on how do we get more people through the door, and the work done in the community about demystifying, about having those conversations, about getting people to understand what these appointments mean. We can then look at breast screening. Now, breast screening is done in a 3-yearly cycle. So the breast screening buses in Keighley in 2021, and it came back in 2024. So we can have a real good look at what the, how many people accepted that invite, between those 3 years. So it's a very clear indication of, for me, it's success. In 2021, it was 59%. In 2024, 67%. That's a big old increase. And again, it's that combination of the PCNs maybe working a bit differently, maybe improving the way we invite, maybe having some targeted phone calls as well in the background, and that work going on in the community about raising awareness, understanding what invitation means, understanding what breast screening is with the community. And that's the so what for me. And the bowel screening figures, I don't have that as a comparison, but the bowel screening figures have gone up as well. Don't have the earlier figures there, but bowel screening's improved as well. And again, that's that demystifying thing. If you know what bowel screening is, the chap the chap who comes in this presentation from Cancer Smart will tell you, it's the test you get in the post. You have to do a poo, then you have to take a sample of the poo, then you have to put it in the post and send it back. And he'll tell you, he'll discuss how you can do that in a way that maybe doesn't sound quite as messy as it sounds for me describing it there. Yeah, and that's something that's been getting talked about and shared around Keighley over the last 3 years through the Cancer Champion Network. So really good stuff, I would say. So that's the so what for me. And again, cancer and cancer screening, we saw the figures earlier about the different areas of Bradford, the community partnership areas, the ones with higher deprivation. We know cancer screening rates in centre of Bradford are very low. Really keen to share and support this work into those areas as well, because I think that Keighley population, it really reflects that centre Bradford population, and we'd be dealing with similar challenges to what we've had. Maybe the figures and the uptake isn't as much of a problem in maybe areas like Bingley, Skipton, Ilkley, but for Keighley, this is a big issue, and it has been a big issue. This has maybe shown that partnership work is really effective and can take on these really big issues. The other one, we've had some really great success working in partnership communities, is baby immunisations, which was in the news last week. Don't know if you saw it. Again, that's involved with community partnership work as well. We can, I think communities and VCS can help primary care and health system take on these big challenges, and it allows, it helps us build capacity and maybe come up with new solutions to take on these big issues. But the so what for me is in those figures. Everything else, absolutely fantastic. But for me to stand here today, or to sit here today in the room on Zoom, and to be able to share the figures, for me is just, it just shows, Kim knows I'm a VCS community guy at the end of the day. I'm just so happy that I'm able to prove that this stuff works, if we can really nail it, and I think we can do that across a whole range of health issues. We chatted on health checks there. I mentioned baby immunisations. Some of the other big challenges we have in health, whether it's diabetes, we can take them on as well, I think, and really show willing.
Can I just sort of come in there, Bill, just to sort of, talk about the CARE project. CARE project has had a massive impact in the community itself. We've trained up about 13 organisations in Keighley who have got trained up champions who are able to give that support, and that it's more like a hand-holding process that you walk through with a person who comes in who's unaware of anything, and these champions are able to help them and to navigate through and signpost them to different places. So we did hypertension training, we did the cancer awareness training with them. We've also done diabetes, we've also done breast screening. We've had quite a range of trainings happening so that we could equip the champions to be able to signpost and support anybody who comes on, into their organisations. And it's been a great, it's been absolutely an amazing project. Thank you, Mandy, for helping us and to navigate through this. This is your sort of historical presence, should I say, within the Core20PLUS5. As I said, that the collaboration and the partnership, we're not a PCN, we are a VCS. It's just sad that you weren't able to show our presentation, Pam and Graham.
I think what I was going to suggest is that actually we've circulate that after the meeting, because obviously we've only got a 10-minute slot and there's so much.
Yeah, that's fine. Yeah,
it's brilliant. What you're saying there, Nancy, is so helpful, because the community health champions were the key to making this work. In terms of that link between what was happening and how the community really felt it on the ground. And you've developed, if you say, the education, you've developed that linkages to another range of organisations. So what we've got now going forward is a network across Keighley and district of people working within the VCS, working with the community. We can use it and utilise it in different ways going forward. It's also helped us to actually look at that broader issue as a community partnership about public engagement there, because it's something that we all grapple with as to how we do this properly. And the health champions, hopefully, if we can manage to keep funding and supporting going forward, will help us to provide that feedback, on the ground feedback to the community partnership to see how we move forward. So I think building on the success of what you've done is giving us so much more potential for the future, with what proportionally is quite a small amount of money. Actually.
It was, Pam. It was just a small amount of money, but it's had a massive impact. And this is because you've got to look at the trust within your communities and the people that will come and walk through the door. So it's a massive impact of having the VCS organisations within this network to be able to deliver such a massive project, really. And I think it was a collaboration and the partnership, as you just echoing what you're saying, Pam Essler, that made it happen. And look at the impact that it's had on the, I mean, you can see that through the data itself. That proves how successful it's been. And hopefully we'd like to roll it out in Bradford if anybody is interested in funding it, and more than happy to help you to develop that and see if we can, we can do something a bit across the district.
Thank you. And as I say, I'll pass on the presentation later, and there's some lovely stories in there that get to the heart as well as the head and really show you what the difference
and I
is.
think I think it's the lived experience of people talking and having that safe environment where they were able to speak. And I think with the Cancer Alliance, I think one of the persons who hosts that spoke about his lived experience, and it's quite an impact on people. And I think it's them having those safe spaces at the same time to allow people to talk, and that takes on quite a success in itself. Thank you.
Thank you, everybody. I think everybody would agree that we could probably have done to have another hour listening to some of these speakers. It's and I'd love to dig in and find out a bit more in terms of how it worked. But I want to make sure that we do leave some time for questions. Is yours a question, Duncan, or did you want to come in specifically about that?
It's just a really quick comment, because I know George and other people have got questions, but it's just to say, because there's been some comments in the chat as well, and we thought long and hard about which examples we were going to include this week. It's so difficult being able to fit all the amazing work in. And what we've tried to do is have a sort of range of projects from right across Bradford District and Craven that have had specific funding from Core20PLUS5. But just to say to, because Yorkshire Cancer Research from Mel, I think Sammy from Healthwatch put stuff in the chat, this is part of an ongoing programme to really promote the practice around reducing inequalities. So we've got the newsletter, we've got loads of really good video blogs on our website as well, and it's really about learning, and it's about learning on a really hyperlocal level as well. So those of you that have put examples of other work in the chat, please get in touch with us and we will find a way of getting that information out there. We've got other ways of doing it. Workshops isn't the only other way. So all I'm saying is hold your good thoughts and all the action you're doing, and we will find a way of promoting that as well. That's all I wanted to take in.
Thank you, Duncan. And perhaps colleagues who presented as well and others might put their contact details in the chat, because that connectivity opportunities for people to network and share outside the events is always good. That's how we really spread the amazing work. Thank you so much to our speakers. I mean, I I spend a lot of time at West Yorkshire level now, and I don't think I'm being biased in saying that these are some of the best examples that I've seen across West Yorkshire. They are really something to be incredibly proud about. But of course, what we need to get behind is how do we do more of it? Exactly what Naz and colleagues are saying. How do we turn this from being like a really special one-off example to something that we do as business as usual? So I'm gonna go to the floor now. Oh, Jo, is yours a question or is yours a comment about?
I think it's, I'm just going to try and come in and just clarify some of the chat for those that are either reading it or Georges, Head of Public Health, and I may have confused people in the chat somewhat, but it does answer your question about sustainability, legacy, long-term investment, learning from what we've done, because the community health checks, Public Health have been keeping a really keen eye on how it's been working and have been collaborating with us on it, clearly because at the moment NHS health checks are funded from Public Health through general practice. But the wonderful thoughts at the moment lead us to being able to think about a revised model of that public health funding. We need to see how it works. We need to ask a few more questions. And certainly we need to meet the objectives of public health in order for that to be fit for their purposes as well as those of Core20. So it answers that question about sustainability, that all of the 70 projects that we've had in the Core20 programme, we have thought from the very beginning, is this sustainable? Is this sensible? Has it got an evidence base, and where might its future be? And because we want all of them to be mainstream, business as usual. So yeah, the ones that we've shown today, we really hope we will find those sustainable funding sources for them, make them recurrent, less short term, and therefore that gives you the opportunity to embed them into common practice, and therefore much better for our communities. So bit of an answer to a question as well as a comment, and clarify some of the stuff that Georges and I have been dropping into the chat simultaneously and confusing people. Thanks, Kim.
Thanks. So yeah, there's lots of activity in the chat. Please do have a good read in there. We did have a question as well about how do, I think it was in relation to Mandy's presentation, how do we pick up those people who might be identified as having diabetes, and Mandy has clarified in the chat that actually the key there is that primary care are at the events, so those people are immediately picked up via logging onto System 1 and can be followed up with their GPs. Now I'm just having a little scan through the chat for other questions, but I think some of those were covered actually. So is there anybody else? George, was your question in relation to, I know you had your hand up earlier.
It was not a question, it was a comment. It's just because we were exactly discussing, it's what George just said. We were discussing the sustainability of funding, and we, local authority, were involved since the discussion of the first version of this guidance, how we can align the existing funding and payment for individual health checks with the need for some sort of extra support for events and outreach health checks offer for them. And specifically in this area, we may see future regular funding coming from public health. It will depend on sustainability. It will depend on how much the practice engage with this model, because it takes a lot of work as well to get an event of like this over the line. But it's totally building upon the experience of community health checks led by your team, that we are starting to offer some complementary payment and see how it works. So let's see how it works. So the practices received an email last week, I think, from David.
Thank you. Okay, so I mean, I've got a question for the panel members actually, because the way that you present made it sound like this is easy peasy. And it is literally the opposite of that, isn't it? This is incredibly hard work. Partnership working is not the easiest road, is it? It's possibly the hardest road, but the one that absolutely makes the most sense and delivers the greatest impact. So what I'm after is a bit of a warts and all. What were the things that you found really hard, and how did you overcome that? What would be your tip for somebody who might be in and amongst finding it hard and thinking, oh no, I might give up? So what are your top tips on overcoming some of the challenging stuff? I'm going to go to Naz first, if that's okay. I can see her nodding very vigorously.
Challenges. Oh gosh, I think what we were, when we were collating the data, and I think our challenge was just to really follow-up meetings with the champions, and and especially doing the visits. And I think that made it really important to know that we were there and they were part of the network, and it was about collating, and it's about educating as well the champions of how to collate the evidence and the impact. I mean, if you can just imagine how many people that we had to, so we had 20 health champions, training sessions, network meetings, information boards, and it was about supporting our champions to put up the information boards and support and giving them that one-to-one, whoever really needed that support to understand what we were wanting, and also to have that network meeting with our other partners like Bill, with Mandy, with the Core20PLUS5 teams. And it was about having those open conversations and talking about our barriers and being able to find solutions, but finding the solutions together rather than just working on our own. So if there was some challenges, we'd say, right, these are the challenges, right? So-and-so is not giving us the evidence. And it was just about chasing up and ensuring that it was very spink and spank from the beginning. So if you're coming on board, this is what our expectations are. So if you can do it, then follow it through. But it was challenging in the beginning, and I think it was slowly as we moved into year 2, and then it got a little bit easier.
There's some really strong messages in there about tenacity, I think, and like really hanging in there even when it's tough, and working together to overcome stuff. Pam.
Yeah, building on what Naz was saying, really, because I think this is where the community partnership itself has got a really big part to play. It's about the culture that you develop in the partnership that allows everybody to take a step back when they attend a 2-hour meeting or whatever, look at the data, look at the issues, actually examine, as Naz has said, what are the things that are going wrong in there, and find solutions. The community partnership is there for the community and the individuals in the community, and we must never lose sight of that and try and find ways actually around it. But I do think the culture and focus is really important there.
And is that about leadership, Pam?
Well, yeah, bossiness, you might say, as Mandy would say after working with us, really. I might say that as the chair, but it is about having a focus in the meeting, I think, sticking to it and not allowing individual organisations or whatever to dominate the debate. This is about the people who live in our community. It's not about us, and we need to develop lists of, problem solving, but also aspiration in there, so we're constantly looking forward.
Brilliant, thanks, Pam. Bill, were you going to come in there?
Yeah, I mean, for me, it's always about the key building block in any of this type of work, whatever it is have we got good, solid, trusted relationships between the partners. And I'll include, I think, for PCNs to be working together, that doesn't happen very often. They can be a bit suspicious of each other. So, I've worked really hard to build good relationships over the years with the neighbouring PCN WACA, so we can do work across our geography rather than it just being PCN focused. I think because I come from a VCS background, and I've spent a whole chunk of my career trying to get money, resources in, because I know what I could do as my VCS organisation in Leeds. I really understand what the VCS can do, but I also understand the challenges we have in terms of resourcing and stuff. I've now had 7 years in primary care. I think, I now understand what primary care can do. I understand what resources it can bring. I understand the challenges they have. My thing is, people will say, why can't we have somebody like you, Bill, in our area? Well, what I say is, I would always say, and I know this is a pity for some of the VCS, but we need some of those people who run and maybe lead VCS organisations to maybe step into that space between primary care health systems and VCS and start, because you're the people who know stuff happen. I've chatted to you about this, Kim. I've chatted to Vicky Beer about it. I've chatted to Vizila about it. Chatted to other people about it. People who can go into that space and inhabit that space, who truly understand what the VCS can deliver, and maybe have a trusted, get some trust from there, but also start to understand what the challenges are on the health side. Because, whether you're chatting to secondary care, whether you're chatting to the care trust, whether you're chatting to primary care, they've got their own operational day-to-day challenges. You've got to figure out how all that fits together. Because I always think everyone's willing to work in partnership, but in reality, they don't have the time to really build the relationship, really understand the problem together. Because when you do that, when me and Naz sat down initially 4 years ago, we came up with a wee solution, which was maybe, we'll train up some champions and we'll support it with a couple of staff, see what happens. And then this is what's happened. This is what's grown out of that. And I think Naz was only willing to give me the time of day because she knew I was from the VCS originally. I wasn't just another health system person coming to chat to her. So I think that's key, the trusted relationship. Because if you've got that and you can have those open conversations, then you can come up with the answers to the challenges, or you can see what's possible between the partners at the table.
And I think sorry, I was just going to say
one other thing, Naz. I'll let you just 2 seconds. Generous leadership. That's the other key thing. We shouldn't be hanging on. People in these systems shouldn't be hanging on to this. And the great thing about KCAN is there's 15, 20 other community partners involved. I look at the Mental Health Connect stuff. There's 25 VCS organisations funded through that funding stream. Generous leadership. It's not somebody's to own and they run it all. If you want to involve that wider capacity we have in the community, there needs to be a really generous leadership outlook there to make that effective as well. Sorry, Naz, on you go.
No, I'm just going to say, I'm just going to echo what you said, Bill. It's about trusted relationships, and that is where it all comes to. And to be able to have that leadership role there, to be able to bring everybody on board. And another thing is about listening. You've got to listen. You've got to learn to listen to what your community wants. You've got to listen. You've got to look at their cultural differences. You've got to bring everything on board. It's like a full wraparound service that you are providing, even as a champion, or even when you're training up culturally sensitive things. And it's just having those open, honest conversations, and that is where that's where your solutions are, and that is where you get your solutions, is being able to have those open, honest conversations.
Thank you, everybody. And on that note, I'm afraid that we've run out of time. So I'm very sorry, Thomas. I see that there's a couple of people who've popped their hands up. I mean, if you wanted to, everybody's putting their hands up now suddenly. If you want to put you've obviously inspired everybody. So perhaps you'll share your contact details. But if people did want to pop their questions in the chat, perhaps we could follow those up afterwards. I absolutely love hearing all of you speak. I think there has been some real little golden nuggets in there, and that I hope that will inspire other people on this call, because tackling health inequalities is all of our business, isn't it? We all have, in one way or another, a power to make a difference, whether that's a tweak in the way that we do our work or how we influence. So I'm going to say a big thank you to everybody who's spoken today. Remind you that there are some more events as part of this series. So I think we've got 3 more coming up. Is that right, Duncan? And we'll share some information in the chat on how you can join those if you haven't already. Have a look through the chat, because colleagues have also popped stuff in there about how you might share some of your stuff. So no doubt there'll be people on this call who might want to share some of the brilliant stuff they've been doing, but also learn more, because I think you'll all be in agreement that there's so much that we could have dug in today in terms of the learning, but crucially, I'll end on a note of hope. Actually, I think I co-chair the Integrated Neighbourhood Health Board for West Yorkshire, and the reason that I'm doing that as a VCSE person is because I actually think that even though we might talk about it in slightly different ways, the potential that sits behind really getting behind neighbourhood health is incredible, and we can only drive that forward if we find a common language to do that. Like Bill, I spend a lot of time translating in between different colleagues, but actually what I know is at the heart of it is that wherever we work, whichever sector, whatever job we do, we really want to make a difference in this area, and neighbourhood health creates that opportunity if we all get on board with it. And like Naz said, truly listen to our communities, walk alongside our communities, and be prepared to do some stuff different. So that means putting some power aside. It means challenging assumptions. It might mean doing some things that feel really uncomfortable, but I'm pretty sure that if you're on this call today, it's because you're really up for it. So thank you, everybody. Thank you to the team for putting the event on, and I wish you well for the rest of the day.
Take care, everyone.